Hello, good afternoon, good evening, good morning and welcome. It's Nurse Richard. Thanks for joining me. Bit of an epic this one, so if you haven't got 17 minutes to spare, then maybe find 17 minutes to spare a bit later on, because this is an epic, but it's a very interesting case. I know I say that about all of them, but this one is particularly interesting because, pardon me, there's a few weird things going on in this ear and there's quite a story behind it. Now, as you can probably see, I'm having real trouble to start with just to get inside this ear because it is incredibly swollen. So already I'm thinking there's possibly an infection here, but what type of infection, we'll get onto that in a minute, although some of you eagle-eyed viewers may have already spotted what they think is going on. But it was a really difficult ear to get inside because this gentleman was actually the father of a friend of mine who I used to play rugby with when I was a lot younger and a lot fitter and a lot faster. And it was his dad, and he was a rugby player as well. I think he's probably in his 80s now, possibly. And he used to play many years ago. And he's got a cauliflower ear. Now, you might have seen this before. It's quite common for a lot of rugby players, particularly if they play a certain position. I'll briefly explain it because I know there'll be some who are watching in countries that necessarily don't watch or understand what again, rugby is played with an oval ball, and there's certain types of positions, and the main one that gets this problem is forwards who play in the what we call the pack or the scrum. I'm taking a swab of this, by the way. That's what this is. I'll get onto that in a minute. Anyway. So the scrum, you might have seen it scrum. If you're American, it's I suppose similar to a scrimmage, but they actually join together, and that's where you get the problem. You get eight players in this particular sport, which is rugby union. 8 players on each team face each other. They all kind of lock up together, and then the referee says, "Right, engage," and they all basically bump heads like this. They try and go into locking like that. And someone who plays that position for a long time, particularly the 3 at the front, with the props and the hookers, not that type of hooker, you get repeated rubbing and trauma, blunt trauma to the ears. And that really commonly gives a lot of these players cauliflower ears, which is, you know, the blood vessels are burst, you get scar tissue, new cartilage growing, they get all deformed and look quite unusual. If you've not seen a cauliflower ear, go and have a look for some pictures of it. So that makes it particularly difficult to get inside this because of all the swelling. Then on top of that, you've got all the swelling due to the infection that this gentleman has no doubt got. You can see all the just dry, crusty stuff, can't you? Makes it really difficult to get in. Anyway, so you probably just saw, I took a swab of this. Now, the gentleman actually brought this with him because they'd been to see the doctor. And the doctor had said, there's definitely something going on in here that's not quite right, but I'd rather find out what exactly it is, i.e. what particular strain of infection, or is it bacterial, or is it fungal? Now, I highly suspect it's fungal. There might well be some bacterial involvement as well. A few reasons for that. You can see at points it looks a little bit fluffy. Which is often a giveaway for fungal infection. When you see these, it looks a bit like cotton wool. It's called the hyphae, which is like the top bit of the fungus. But there could be bacteria too. But it's the backstory with this gentleman that's kind of, I think, led him to this point. He had a shoulder, I think he had a fall, if I'm not mistaken, and he had surgery on his shoulder. I think they removed a large part of it, and I don't think they can fix it. Due to other health conditions. And I think he developed sepsis, which is obviously an infection that takes over everything. It can be potentially fatal, really serious. So they put him on, he's been on a lot of antibiotics, and I think remains on them long term to prevent this from getting any worse. I think at the point he'd come to see me, he'd already been on antibiotics for a number of weeks, possibly more than a month. And I had seen this gentleman before. He is a regular attender to me because he wears hearing aids, has particularly narrow canals, and so they do tend to get blocked up quite easily. But believe it or not, I actually saw him about 10 to 12 weeks ago and the ear looked absolutely fine. It looked as it normally did. There was just what you would call just ordinary freshly shed skin, bit of wax, nothing like this. It looked absolutely nothing like this. So I suspect because of, you can just see the little furry bits there, because of all the antibiotics it had, it's kind of it kind of messes with the natural flora in your body, so to speak. That's, you know, we all have natural flora and organisms everywhere, on your skin, in your ears. Some are fungal, some are bacterial, and obviously the antibiotics has been to address the big bacterial issue that he's had after his surgery in his shoulder and the chronic infection he's got there. It's not uncommon to get fungal infections when you're on antibiotics. I used to see it quite a lot in my old job. It was really common for people when your immune system's been clearly messed about with, and it's a bit all over the place for one or the other to take over, but particularly fungus. And I think that's probably what's happened in this ear, is it's just taken over completely because there's like an imbalance in the amount of bacteria and the amount of fungus that's normal in this ear. I must preface this by saying I'm by no means an expert in microorganisms. I know more than the next nurse. That wasn't our job. It was our job to recognise it and to spot it, and then pass that on to the medics and what have you. But obviously, because I've been doing this for a while in ears, I know a little bit more than most nurses, because this is what I specialise in now. But I did used to see it a lot. It was really common for patients who was to get if there are problems with their immune system, to get things like oral thrush, particularly unpleasant, and all kinds of problems. But he didn't really have many symptoms, this gentleman, other than not being able to hear very well. He's almost, and obviously he wore hearing aids. You put a hearing aid in this, it's not going to work in the slightest. And the problem is, no matter how well you clean your hearing aids, every time you take them out, put them in, it's probably going to be just like a vicious circle. It'll keep proliferating. There you go, there's the word of the day for you. And it's just not going to go. It doesn't get water in his ear. That's not been the issue here. I think it's all to do with the problems that his immune system has been having and the treatment he's been having, why it spread so rapidly like this. And it did actually remind me, and I've just had a look at his case as well, because for something to appear this quickly, like I said, 10-12 weeks, it's quite unusual. It reminded me of an O'Connor from Durham Hearing had a case. It looked similar-ish to this, and when you get this rapid skin turnover, because it's, as you can see, it's all white. It's not because he'd put any drops in there that might bleach it per se. It's all really freshly shed, a dead skin, and I think the one that he had was white like this, and I think he got to the bottom of that eventually, that it turned out it was fungus. I think it was aspergillus. Correct me if I'm wrong, but go and have a look at that case. That's a really interesting case. I think it's called rapid skin shedding. I think there's about 2 or 3 on that, but go and have a look at that, because it doesn't look dissimilar to this. And I'm hoping that it's not as problematic to get rid of, because I think the one I saw of him, it's like 3 weeks in between treatments. But they are notoriously difficult, especially with all the other stuff that he's got going on. Bless him, the poor chap. So I do suspect that it's going to be quite problematic to shift all this with everything else that's got going on. So I might well have to see him again. And I'll share a video if that is the case, which I'm pretty sure it will be. Now, we're already getting a little bit deeper into the ear, but because it's so swollen, it's really tough to get in this. And you're not going to get every single speck. That's nigh impossible with an ear like this. And you have to bear in mind what the patient can tolerate as well. I'll be honest, I was really happy with everything we could get out of here. But there's always going to be a few little specks here and there. What you're doing here when you're removing all this, you're giving the medication, which is more likely antifungal drop, the best chance to work. Because the more of that can get in and settle on freshly shed skin, on new skin rather than the dead stuff that we're peeling away, the better. So you're just giving it the best chance to work. But it was quite shockingly quick. This just came in such a short space of time. But like I said before, there could be other stuff going on in here as well. Could be fungal, bacterial, everything. It's the full-size tube all the way through so far. I think I did go to the fine-end tube a bit nearer towards the end. Yeah, like I said, I knew the gentleman because I played rugby with his son. I obviously knew him as well quite well. I wasn't in one of the positions where you commonly get these cauliflower ears. That's why I managed to get away with it. It's generally the big ugly men, the big ugly strapping chaps who ended up playing in that particular position, and I'm not that. I used to do another. I was in another position. I was the scrum half or the winger, the little fast rapid one. Certainly not anymore. But I never got involved in all that mucky stuff, rolling around on the floor, unless I absolutely had to. But my playing days are long behind me. Playing at a serious level anyway. I think I started when I was 6, and I think the last competitive game I might have been about 35, 36. I mean, mostly I had to stop because I got an injury in my neck. Not because, well, partly because of rugby, but mostly because of nursing. Not many nurses will have a good back or neck, you will find, because of the stuff we have to do. And I ended up having a surgery and having a replacement. They had to take a disc out because it was just crushed and popping out all over the place. So I've got like not a metal plate, it's like 2 spikes like propping open the vertebrae there. So I do still play our version of the game, but I'm not allowed to tackle anybody. Now, as you can see, we can already see the eardrum here, and I would still rather get some of that in the top left corner there, but it wasn't long after having a go at this. I mean, I'm already happy. As was the gentleman, his hearing was pretty much restored at this point. But we got to a point and did find it a bit uncomfortable because it was so difficult for a start to get, I think I've gone down to the fine-end tube here, to get in that top corner there, because the ears are not straight, and this was very swollen. It was a very tight ear to get into anyway. And then you throw a bit of all this swelling into it and it makes it almost nigh on impossible. But because I had to kind of stretch it open so far to try and get to that bit, we had a quick go and a bit came, but not all of it. But you have to bear in mind, think back to what this ear looked like beforehand. It was very different. So I was more than happy with everything we got. In fact, I was delighted, actually. I was really happy with it. And so, going back to you saw me putting a swab in. Those are bigger than a cotton bud, those swabs. It's like a long swab, about that much. And I tried to get a little bit by pushing it in. Obviously, I didn't want to push it in and push some debris back there. So what I also did, which I found can work a lot better, actually. That's why you hope that some of the debris stays on the tip of the suction tube when you pull it out, because when you can stick it on the suction, if it all disappears, oh, that's gone now, I wanted to get a sample off that. But if a bigger chunk, especially a more wetter one, ideally, because you're more likely to get something decent from that, stays on the end of the suction tip, you literally pull it out, and I asked him to pass me the swab, the gentleman's son, and I'd literally just smear it all over the end of the swab. So I'm pretty sure we got plenty on it, because I must have rubbed it with a fair few amount of chunks that I pulled out this ear. Excuse me, a little tickle in my throat. Time for a brew, possibly. I know it's been a long one. Sorry about that. Nope, still not gone. Anyway, where was I? I'm not re-recording this again. I'm already up to 14 minutes. Never do outtakes on these things. Where was I? Oh yeah, the swab. So I'm hoping that the swab result comes back pretty quickly. because the quicker you can get some treatment in this, the better. As it is going to be a bit difficult to get rid of. And this is the part that I was talking about before, the part right down there on top of the eardrum, which he was finding it particularly tricky. I was finding it tricky to get in, and he was finding it a little bit uncomfortable. Now, he was trying to be a bit of a trooper. Rugby players tend to do that. Big hard macho men. No, I'm all right, I'm okay. But you in chaps like, especially in the older generation, if something's uncomfortable, they'll be like, well, I expect this. Let's just get on with it. Quite, what's the word, stoic. And they'll just let you get on with it. But you're looking for the non-verbal cues. And when you're looking at someone's face, when you're coming out, you can't look in two places at once, but you can have like peripheral vision, which I was trying to keep a little eye on him, and I could just see he was just like scrunching his face up a little bit and just wincing a little bit. I did ask him, I said, is this hurting? And his response was, well, I can feel it. But so it was at that point I decided I'm not going to persevere with this poor chap all the way down there. But have a look at it now compared to what it looked like before. Yeah, it's still messy. And I'll just look how swollen this is as I pull it all out there. Now this was his other ear, which as you can see, I actually did this one first. I've just put it at the end of this video, because there's no way, with the best will in the world, you can have the best infection control and change everything and decontaminate it. You don't want to risk spreading anything from one ear to the other when you've clearly got a nasty infection in that one. So I did this one first, but I've just put it at the end of the video. And you can see, got a little bump there. Now I don't think that's anything to worry about, to be honest. I think it's just a little polyp, something that you can have just in response to some trauma. You know, he does obviously have hearing aids, he pokes them in and out all the time, and he's probably had some infections in this in the past, so I'm not too concerned about that. Obviously I've sent pictures of this and a letter with some images to the ENT specialists in the hope that they can get on top of this pretty quickly, because I'd rather they had a look as well as the patient's GP. Anyway, I hope you enjoyed that. I know it was a little bit of an epic one and it went on a bit. And I had a lot of other stuff that I was going to tell you about, and I completely forgot because I just rambled on because it was such an interesting case. But I hope you enjoyed that. But for now, take care of yourself and I'll see you soon. Ta-da.